This conference will now be recorded.
Welcome in, everybody. Today we're going to be talking about lifting and moving patients, specific equipment that we can utilize, one rescuer moves, two rescuer moves, and what the difference is between emergency and non-emergency moves. So first, let's talk about the objectives. This is what we want to accomplish today. Some key terms as far as lifting techniques and equipment, considerations when we are utilizing that plan, when we do have that patient in a specific location, how are we going to get them from point A to point B, do it safely and in a time efficient manner, depending on the injuries and or disease processes that's actually affecting that patient. Proper body mechanics, and then we will also be utilizing the lifting and moving lab, which will be done on Wednesday with Nick Jorgensen. So first, let's talk about protecting yourself. 1 in every 2 EMS providers within our line of service is going to sustain a injury in regards to lifting and or moving a patient. So the first thing when we're looking at body mechanics is utilizing these different terms and or scenarios when we are formulating that plan. So first we got to be thinking of the object that we're moving. Are we moving EMS bags out of our ambulance or out of our fire truck to our patient, or are we lifting a 400-pound patient in the basement and we have to bring them up the stairs to our waiting stretcher? Knowing your limitations, if you respond with a 2-person group or a 3-person group in the scenario that I mentioned earlier, that is not going to be enough resources on hand. So again, knowing your limitations and knowing when to call in for additional resources so that you don't harm yourself by trying to do too much. Communication is key, especially when you're utilizing as a team. When we're positioning our feet, always do that shoulder width apart. Make sure that your feet are flat. Always use your legs when we are lifting. It's kind of like going back to high school when we took weight training, what have you. Never use your back whenever you're lifting. And then never turn or twist, and never compensate with lifting with one hand. So when we're compensating with lifting with one hand, what we're doing is we're losing our balance of our system. And again, we're straining a significant amount of our muscle mass on one side. When we turn or twist, that's when we really see those significant back injuries. And then always keep that weight close to your body. When we're doing that, kind of like I taught you guys when we were doing our BLS CPR portion, is that with that weight close to us, that's where we're utilizing the most muscle mass that we can possibly use. Now, in comparison, if that weight is farther out away from us, we are not utilizing all of our muscle mass. Most of the time, we're going to be utilizing our back muscles because of that object being so far away. So with key terms, first, what we're looking at, power lift. Power lift is a lift from a squatting position. That weight is going to be lifted close to the body. Feet are apart and flat on the ground. Body weight on or just behind the balls of our feet, and the back locked in. The upper body is raised before the hips. So this is going to be the most amount of weight, energy, and the safest way that you can actually perform a lift. Next is power grip. So when we are actually utilizing the surface of our hands, this is what we should be doing whenever we're actually lifting something. Power grip is gripping with as much hand surface as possible in contact with the object being lifted. Hands are at least 10 inches apart when we are utilizing this. So here, great example of good body mechanics, both using that power lift and that power grip. So you can see both these rescue providers, their feet shoulder width apart. They're utilizing their muscle mass in their legs as far as lifting, and they are not using their back. You can see that back is basically locked in at this point. And then when we're looking at the power grip, you can see as much of their hand surface is located on those straps as can be. Another example of using that power grip. So this rescue provider is utilizing the stretcher operation. And again, those hands are at least 10 inches apart. What I don't like about this picture is that the hands are one way and the other. So when we're doing that, we're basically using the pushing and pulling format of utilizing energy. And so we're not going to get the best amount of power lift technique when we are doing this. So either have your hands upturned or vice versa. With emergency moves, when we are providing an emergency move, we are going to move a patient for protection or for care, which C-spine precaution is not taken. So traumatic event, accident, patients caught basically on fire, and if we don't move them immediately, then they can sustain life-threatening injuries. This is where we're going to utilize the emergency move. We need to remove them from that area based on patient safety, or maybe that patient needs to have CPR performed on them. That's where we would utilize the emergency move. So here, great example, you might have to utilize that emergency move in the event that this patient's not breathing or in cardiac arrest. We're going to need to get them from that position outside of the car and then start doing CPR. Another example, so this would be a case in which the scene is hazardous. We need to remove them if we can, if we have that capability in order to provide proper patient care. Now, urgent moves, very similar to that of the emergency move, only we are going to be taking C-spine precaution. So here, an example, let's say this patient was down and didn't exactly get clipped by that trailer. They're still alert and oriented and or talking to us. No immediate interventions got to be performed at this time. We can go ahead and remove them from that car utilizing C-spine precautions. So basically think of a slowdown process in this case. Same thing, we have a patient who's drowned. Anytime we have a water-related emergency, we're always going to assume that there is some type of C-spine injury, so we should be taking C-spine precautions if we can. Now let's get into drags and lifts. One rescuer drag, we have the closed drag. So again, this is very nice utilized because we're using that patient's body weight in order to slide them. We can see too, even with this one rescuer drag, we're still maintaining some type of C-spine precautions. Now it's not ideal, but again, when we're utilizing emergency moves, or if we assume that there's no C-spine injuries, we can utilize that. Can also utilize under the arm drag. This works really well too because you're getting the major body mass up off the ground. And it makes it a little bit easier for that rescuer to actually slide that patient to the position desired. Same thing under the arm drag. We can utilize this going down the stairs. So think of our MCI issues that we're running across throughout the country where we're moving patients off of the X. And we'll talk about that too once we dive deeper into EMS operations and mass casualty incidences. Here, this is utilized as a firefighter drag where you're actually tying the individual's hands together, and then you're basically creating that nook between the arms and then actually pushing that patient to the desired location. Feet drag, not the ideal way in order to move a patient because you have no control of their head at all. But there are certain situations where you would actually utilize this drag, but again, not highly desired because you're going to be bouncing that patient's head off the ground. And then here we have a blanket drag. So if you can reposition that patient onto a blanket utilizing a log roll technique, then you can use that blanket in order to slide them across the floor surface to your desired location. Other moves that we can do, again, one rescuer. So this is basically an assist where that patient is still alert and somewhat oriented and can take direction. So it's a buddy system. Next, you have the firefighter carry. So very difficult, especially when a patient is unresponsive, because all of that weight is basically dead weight. So easy to see on TV, but in the real world, it's relatively difficult. Again, you're going to know your limitations. Can you actually carry this patient or this object a significant way. And then your buddy system carry too. Another way, as far as firefighter carries go, this is much easier than under the arm technique. So you're balancing more of that body weight through distribution of your major muscle mass. And then the piggyback method too. Again, this can be utilized for smaller patients, and again, who are alert and oriented, who can actually take some direction when you are moving that patient. With our two rescuer technique, if we're moving that patient, again, we can use the double buddy system here. Now let's talk about some equipment that we have on our rigs, whether they're an ambulance, whether they're a fire truck. First, we have wheeled stretchers. So these are great if you can get them in a proper position. Couple of different specifications that they have. Some of them are powered stretchers, some of them are manually driven stretchers. So this is manual driven, so you actually have to lift that stretcher into the proper height that you want it, especially when you're going to load it in the back of the ambulance. The negative consequences behind this is they tend to be heavy and they don't go over stairs very well. So oftentimes we're going to utilize this. We're going to get the stretcher as close as we can to that patient or that house. And then we're going to utilize a different piece of equipment from getting that patient inside the house, out of the house, onto the stretcher, and then the stretcher into the back of the ambulance. Here's an example of a powered stretcher. Again, these are great pieces of equipment because you don't have to actually lift that patient when they are on the stretcher. However, getting that stretcher into a specific location can be really difficult based on that weight of that stretcher. Next, great piece of equipment is going to be the stair chair. So this can be utilized in twofold. You can basically utilize it as a wheelchair, or you can utilize it as the stair chair. Stair chair's got tracks on the back that you can pop out so that you can go down the stairs, which is much easier because basically you're using the patient's body weight and that track system in order to guide them slowly down to whatever floor you want. Now you can also utilize this going up the stairs, but it takes a little bit more energy, obviously, in order to move that patient up the stairs. Big positives, takeaway is going up and down the stairs. Again, this is a great piece of equipment. And again, if you've got long transfer time or a long transfer distance, you can put them on that chair and then wheel them. We can't utilize this, however, as far as negatives, if a patient's got a Cspine injury, because that patient's got to be fully immobilized with a C-collar on. And again, it's very difficult as far as airway management in the event that this patient isn't breathing or can't control their own airway, because basically their head is kind of free floating. Now, a lot of new stair chairs, they have straps on the handles on the top that you can actually strap that patient's head in and control their airway a little bit better. Next is a spine board. So a spine board oftentimes is going to be utilized for a traumatic patient where we have to maintain C-spine precautions. However, we can use this for different lifting and moving techniques as well. Positives behind this is that we can get a lot of rescuers on both sides in order to lift that patient. So we can utilize a bigger team, and as a result, it's going to be less body weight per rescue. Negatives behind this is the fact that it's extremely uncomfortable for that patient because they're lying flat on that hard surface. Other things that this can do is it is positively buoyant, so we're going to utilize this for water-related emergencies as well because it will float and it's actually buoyant enough to actually float that patient to the surface as well. Next, we have a scoop stretcher. Scoop stretcher has kind of lost favor as far as the EMS world goes, but it is starting to make a comeback because it is a great piece of equipment. So when we're utilizing a long board or a spinal board, what we have to do is log roll that patient onto the backboard. With a scoop stretcher, what we're going to be able to do is actually separate those two pieces with that scoop stretcher, slide it into place underneath, and then we can go ahead and lift that patient. So hip injuries, leg injuries, injuries where we don't have to worry about C-spine, this is a great lifting technique from getting that patient from the floor or the ground and then up onto the stretcher. Nice thing too is once we get them onto the stretcher, then we can go ahead and break apart that scoop stretcher. Now they're laying on the soft stretcher in comparison to being transported on a scoop stretcher or on a long spine board. Some negatives behind it: when you are actually closing the two pieces together underneath the patient, oftentimes what will happen is you actually pinch the back tissue and you can cause harm for that patient or discomfort. Other things is oftentimes these scoop stretchers are metal, and so in the middle of the winter and they're out in the truck, it can be really cold on that patient as well. Next, we have a flexible stretcher. So this is going to be a rubberized or flexible material. They also go by Manta. And so with this, again, this is perfect utilization if you have a patient who can't be transported or guide themselves out of the house and you don't have to take C-spine precautions. It's much more comfortable for them to utilize in comparison to a spinal board. And again, you have a lot of different handles there for a lot of different rescuers that can actually utilize when lifting and moving that patient. Now, negatives: when you do get that patient on the Manta and you start to move them, you can't properly position their body. So they have the tendency to kind of be rolled up a little bit. And so you can't protect their airway. If they have any type of musculoskeletal injury, let's say a broken ankle or broken long bone, it's difficult in order to stabilize that injury. That's why a long spine board sometimes is a better call than a Manta, even though the Manta is a little bit more comfortable. Our immobilization devices, again, this is going to be used when we have a traumatic event and we're concerned about the spinal cord. And so this is our long spine board in utilization with maintaining C-spine precautions. So you can see we're utilizing those orange head blocks. And again, that patient cannot move their spinal column at all in this case. Other piece of equipment that we can use, this is called the KED board. So this is going to be utilized when we have a sitting patient who's got a possible C-spine injury. We can guide that around the patient, kind of fits like a jacket, and then we can actually move them out of the car while maintaining C-spine control. Not oftenly used within the EMS world anymore because of the amount of time that it actually takes to put on that patient and safely guide them. When we're dealing with motor vehicle accidents and actually being on the highway, it's very dangerous for us. So a lot of EMS providers err on the side of caution and try and get that patient out sooner rather than later. Again, it's going to delay actually getting that patient out of that car, and you're kind of on a dangerous ground there. Another technique, as far as our sitting patients go, would be our short spine board. We can utilize that as well for our sitting patients and bouncing them out of that car. We don't even see this very often in EMS protocols and guidelines anymore. So how we move those patients with a C-spine injury, what we're going to do is maintain C-spine precautions, holding that head in that neutral position, and then imagine that spinal column kind of in a linear or straight position. So if we're going to log roll them, that patient or that rescuer, whoever's got control of the head, is always in control. They're going to count to 3, log roll them to the right, and again, you're maintaining that C-spine the entire time. Patients with no suspected spinal injury, so this is the extremity lift or the fore and after lift that you can utilize. Like a couple of paramedics told me a long time ago, some patients got one more good walk in them. So if a patient is able to move themselves to the stretcher and they're not compromising their injury or their illness, err on the side of caution and see if that patient can do that for you. Because again, you're limiting your exposure to any type of injury when you are lifting that patient. You can also utilize that direct ground lift, so we're lifting that patient from that position onto the stretcher or onto the manta or other piece of equipment. Sheet drag, so this is widely used. So if we go to a nursing home or a patient's in bed and we can get that stretcher right next to that bed where they're located, that sheet underneath them, we can simply slide that sheet from the bed to the stretcher. Or once we transport that patient and get them into the ER, we can then slide that patient on that sheet from the stretcher to the hospital bed. Another way of that direct ground technique, only instead of utilizing 2 people, we're actually utilizing 3. Patient positioning, we'll go over this again. It is in your anatomical terms. So this is the semi-Fowler's position. So this oftentimes is the most comfortable and most commonly used way of actually transporting that patient. Whenever we refer to a patient in supine position, they are on their back. So anytime there's an airway compromise or a suspected C-spine injury, make sure that patient's in the supine position. We never transport a patient in a prone position in any way, shape, or form, because that can trigger that airway asphyxiation. Next, we have the Trendelenburg position. So this is not used anymore. It's going to reference in your EMS textbooks. But again, this should not be utilized because there's a lot of research and data out there as far as negatives with that blood flow, and it can disrupt the preload and the afterload of the heart. That does it for lifting and moving patients. And again, when we meet for lab session, we are going to be practicing and demonstrating all these techniques. Thanks.